Presenting Occult from Medicine 1. Presenting Mr. S, a 33-year-old who presented with fever and for 15 days and loose stools for the past 4 days. Fever for the past 15 days and loose stools for the past 4 days. So the fever was high grade in nature. It's associated with chills and rigors. It was continuous in nature and associated with generalized myalgia and headache. It was there for the past 15 days. And in the past 4 days, he started developing loose stools, which was large volume, watery, and non-bloodstained and without mucus. So there was 2 episodes of vomiting also in the last 2 days of presentation, which was non-projectile and non-bloodstained. There were no other localizing signs noted. There is no recent travel history. There are no known comorbidities for this patient. No substance abuse. So here on examination, patient was conscious and cooperative. Was normally built, and his pulse was he was tachycardic on presentation. Was 140 beats per minute, regular, and blood pressure was 120/80 millimeter mercury, and respiratory rate was 20 per minute, and he was febrile on presentation, 104 degree Fahrenheit. Otherwise, general examination, JVP was not elevated. There was no pararectal cyanosis, clubbing, lymphadenopathy, or pedal edema noted. No rash or eschar noted. And gross head, eye, ear, nose, throat examination was normal. And on systemic examination, cardiovascular system examination, respiratory, abdomen examination also normal. And no major findings were there on examination. So the patient presented with an acute undifferentiated febrile illness and with the recent history of loose stools and was also vomiting. So with this nature of the course of illness, we thought of an first enteric fever as a differential, scrub typhus, malaria, and leptospirosis. These were the differentials considered. And initial investigations, his hemoglobin was 14.3. He had total counts were normal on presentation, also with 9,000 and neutrophils slightly on the higher end, 65%, and platelet counts were normal, total at 21,000. He had elevated liver enzymes with one AST of 133 and ALT of 98. And serum electrolytes are significant for mild hyponatremia, 131. Otherwise, renal parameters and other electrolytes were normal. And urine routine shows proteinuria and hematuria at the point. And CRP was elevated, 134. And stool routine parasites was negative. So for the chest X-ray was done. Chest X-ray was also normal, and his initial evaluation included scrub typhus serology, which was negative, and malarial parasites were also negative. So further, we sent a blood culture upon presentation and in the ward also, and it grew Salmonella typhi. So it was sensitive to all medication, cotrimoxazole, azithromycin, ampicillin, and chlorphenol and ceftriaxone. So he was started on azithromycin tablet, azithromycin 1 gram 1 gram dosage, and following which he was still having persistent fever spikes during the course in the ward. High grade fever spikes were persistent, 102 degree Fahrenheit. He was started on the same, and gradually his liver function test started to increase. His SGOT, SGPT levels showed progressive worsening of suggestive of hepatitis. And on day 5 of admission in the ward, he developed severe abdominal pain and tachycardia. Was also there. As fever spikes are also there. Tachycardia and severe abdominal pain was the complaint given at the time. So abdominal pain in the 3rd week of enteric fever. So now we have a diagnosis of enteric fever, and it's been almost 15-20 days of fever presentation. So the 3rd week of enteric fever, a lot of abdominal. What are the differences that we can consider for an abdominal pain? Small bowel ulceration and ulceration leading to an intestinal perforation, especially a terminal ileum is possible, so which can progress to peritonitis also. And second is an acute acalculous cholecystitis, which has a high risk of perforation and necrosis as well. Pancreatitis is possible, hepatitis, and hepatic and splenic abscesses and granulomas. These are the possibilities, possible manifestation in the 3rd week. So approach. So our patient had an acute onset abdominal pain onset, and it was moderate to severe in nature. And the character was a dull aching pain, and the site was predominantly in the epigastric region and in the left upper quadrant, and it was a non-radiating type of pain. He had, on examination, he had tenderness in the epigastric region as well. His vitals were, except for the tachycardia, his blood pressure was normal at that time. And there is no change in the pain nature upon changing the position. There is no change. So with this change in position, we can make a difference between these three the differentials also. Like for peritonitis, the patient one of the most lethal complication that we can see expect in this perforation leading to a peritonitis requiring an emergency surgery or cholecystitis. So based on this change of position, also we can differentiate the pain. Like if the peritonitis, the patient will be stable. Even in slight movement will cause a worsening of the pain. Even coughing can increase the pain, and the patient will be mostly lying still on the bed, which is unlikely for an abdominal pain. Usually, where we see patient will be severely agitated, but these patients usually lie still. But he wasn't like that. And colicky type of pain, he didn't have an actually colicky type. It was continuous pain. And pancreatic pain is usually relieved by an upright position and bending in a fetal position. They'll usually be there. So these weren't there for patient. There is no change in position. So coming to the most common first thing we want to rule out where an acute acalculous cholecystitis. This pain is typically in the severe right upper quadrant pain and an epigastric pain, and it typically radiates to the right posterior region of the thorax or the tip of the right scapula. And on examination, there can be palpable distended gallbladder. And in acute setting, when there is a sudden distension of the biliary tree, there may not be a biliary colic. There can be steady, continuous pain. So the pain that biliary colic, the word can be misleading, and the patient can get quite sick and go into sepsis as well. His vitals are stable, and his pain was predominant in the epigastric region and in the left upper quadrant. And second one we are worried about is a peritonitis. Why this happens in the third week is because that at the site of entry of the Salmonella typhi, when the bacteria enters the abdomen, the Peyer's patches, they usually get thickened, and it forms a longitudinal ulcer compared to a tubercular ulcer. Usually the comparison made. Tubercular ulcers are horizontal and they produce more of stricture. But typhoid ulcers are transverse in nature, and they produce longitudinal nature and are more prone for perforation. So this perforation will eventually lead to a peritonitis, and the peritonitis pain usually, as we saw, positional change, like a simple bed shaking itself, they can't tolerate, can be there in generalized peritonitis. And restricted movements with respiration. If the peritonitis is localized to a particular area, if there is hepatic abscess or splenic abscess, the rupture of the abscess can lead to a walled off peritonitis due to the surrounding structures, which can produce a localized tenderness with guarding, and that area may have a decreased response with respiration. And rebound tenderness can also be seen in these patients and peritonitis, and cough tenderness. So this cough tenderness is helpful because peritoneal pain can be very severe, and upon examination they'll have a severe discomfort. So if we ask the patient to cough, they'll locate the pain, localize the site, and then we can make a further assessment based on that. That's called a Dunphy's sign and can help in localizing the site. So our patient also did not have any postural change, no guarding rigidity was also noted. So these two main things were ruled out. So in this thing, then other possibilities could be a pancreatitis, hepatitis, or hepatic or splenic abscesses. With the pain being more of a left upper quadrant pain, splenic abscesses are also considered likely. So this was in the third or fourth week of this, the Peyer's patch necrosis lead to the GA complications. So we went ahead with an emergency ultrasound at that night. So ultrasound showed multiple ill-defined heterogeneously hypoechoic areas. Multiple hypoechoic areas were noted in the spleen, suggestive of an multiple abscess. Small anechoic areas. The largest abscess was measuring 10 cc in the lower pole of the spleen. So the diagnosis was made splenic abscess secondary to Salmonella bacteremia. So typhoid causing splenic abscess is a very rare complication, and it was very rare extraintestinal complication. Why it is very rare? Usually spleen itself is resistant to infections compared to other places. Other places get easily seeded, but spleen, because of its high immune activity and high phagocytic activity, usually doesn't get infected. And if it's getting infected, then there should be some predisposing conditions for these patients. And these splenic abscesses were common in the pre-antibiotic era, when the patient getting the antibiotic were very much delayed. But here, usually they receive antibiotics in the local place, and these are very uncommon these days. Pre-antibiotic era, the incidence was 2%. Now it is less than 1% is noted, and only case reports are available. Less than 100 case reports are available. And usually these splenic abscesses are solitary. Related to typhoid, but our patient had multiple abscesses, and the diagnosis usually made by the history and examination. History of suggestive of an enteric fever, and we have a diagnosis of enteric fever as well. And on examination, where the patient had the pain, these can helpful in localizing. And the imaging, ultrasound and CT abdomen can be helpful. So what are the predisposing factors that can cause this splenic abscess? Sickle cell disease, IV drug abuse, subacute bacterial endocarditis, in patients with uncontrolled diabetes mellitus or immunodeficiency. These patients have a higher risk for a splenic abscess. But our patient did not have any of these comorbidities as well. So only multiple case reports are available. There are case reports for a similar picture where young patients without any comorbidities also getting this type of infection. Very rare, and multiple abscesses even very rare. So that is it. So just one question: if this patient complains of pain that is referred to the left shoulder on gentle palpation of the abdomen, what would you suspect? Hmm? Definitely. So how this patient has a splenic abscess, then what would happen? Yeah, developed a sudden onset left shoulder pain. Yeah, that's how this forms is. You should actually we should think of a complication. Why this splenic abscess is very important to be diagnosed is that can happen rupturing of the splenic abscess, and if it gets ruptured, yes, and if it gets ruptured, usually there can be blood in the peritoneum, and a local examination of left shoulder will be completely normal, no postural changes, nothing will be there. But if we make the patient lie in a supine position and make the leg slightly elevated, the blood in the peritoneum pushes to the diaphragm, causing an irritation of the phrenic nerve, leading to a referral of the pain to the left shoulder. So this can happen, and there are case reports of this happening also. Peritonitis secondary to a ruptured splenic abscess in Mangalore in India also. There was a incident such as that requiring an emergency surgery, and splenectomy was done. Here also similarly, lower pole, the patient had an abscess and it completely ruptured. It was noted on a CT abdomen, and emergency surgery was performed after the patient was well. And second, similarly, non-typhoidal salmonella can also cause similar ruptures there also. This was one more case report I was able to find in this topic. This was very big, voluminous abscess and required emergency surgery also. So it is very important to diagnose this early, because it can present as a vague abdominal pain also. So it is we should have a act for it. And then management wise, the predominant management is giving appropriate antibiotics for a prolonged duration of time as an abscess. So I will usually prefer 6 weeks of antibiotics. Second thing is, if the percutaneous pigtail drainage can also be done to reduce the burden, because if there's a chance of rupture also. And because in olden days only the option was splenectomy. Now we have an option of US guided or CT guided percutaneous pigtail drainage, and splenectomy is also an option in case of this rupture or multiple splenic abscess, gross splenic abscess with thick pus with septations, which can't be aspirated out. So that splenectomy is an option. So our patient, he was planned for a 6 weeks of antibiotics with a tablet azithromycin 1 gram OD. He actually, his fever actually settled after 2 to 3 days, and considering his vitals are also stable, so we didn't go ahead with the percutaneous pigtail drainage. One more thing was, it wasn't quite liquefied at the time. So we planned for repeating the ultrasound and planned for a CT guided drainage if there's more liquefaction, or if the size is increasing, if the abscess is progressing, we planned for a drainage procedure. And our patient, the repeat ultrasound twice we have done, which shows the resolving abscess. The size of the abscess are coming down, but there's more liquefaction now. We are, as of now, he's asymptomatic and is under close follow-up also. We are trying to repeat. So the learning points are various complications of enteric fever, and to watch out for the rare manifestation of common diseases.
Thanks. Just a couple of questions. This gentleman was an alcohol. Was he?
No.
Not an alcohol consumer. And how common is hepatitis with typhoid? That's also quite rare. I mean, we think that. Do you see that commonly in typhoid? Because and this guy's OTPD went up with
Yes.
with therapy. That's also something
Yes.
that's maybe was he only on azith? What is he on azith?
Only azithromycin.
We didn't give him. You didn't give him ceftriaxone at all. From the beginning, he was receiving IV azithromycin.
No, tablet azithromycin.
Tablet azithromycin. Okay.
And hepatitis started resolving after he took a time to defervesce also after the 20th day, 23rd day.
Did you do BBVS on him?
BBVS, no, we haven't.
You didn't do BBVS, but anyway, it resolved. You're saying it resolved.
It's resolved and it clinically improved and is on follow-up. So,
sure. Okay. Any other questions?
He actually, was around 8 days.
Yeah.
So we were wondering whether to give him dual therapy or not.
Yes.
But because he started defervescing, we just thought we'd follow him up.
With
we didn't start on dual therapy. systemic abscess doesn't resolve, we move up to field drainage.
Okay.
There have been case reports of managing it conservatively,
Conservatively.
where patients have been.
Now, I think that typhoid goes into the bones also, because salmonella typhi loves the bones. So that's what we've always been taught. Okay, thanks. In fact, we've written up a case of aortic fistula due to salmonella typhi. That lady died. It was long.